So I was asked to come and speak about this DMAR project, which you kind of heard peripherally about yesterday, which is some quality improvement work we've been doing in Calgary. So this project I've been working on with Dr. Oliver in Toronto for about the last decade, and it's really centered around how to use data to optimize the care that we deliver to the end-stage renal disease population. And we've done this work in about 12 or 13 different regional programs now in 3 provinces, and it's evolved a lot since its early days. I had this naive notion that if you were able to collect really high quality information and put it in front of people, you could change practice. And what we learned over the course of the last decade was that that's just part of it. You need to have good data and you need to understand things, but you also have to help people understand what they're doing, how they might improve that if they want to change an outcome, and then you actually have to change behavior, which turns out to be the more difficult part, and often takes the most time. So I have some disclosures. The only one that's not on here that you didn't see yesterday was that Janssen donated some money to our division in an unrestricted grant that was used to support the DMAR project in Calgary. So I'm going to briefly just recap how we approach the anatomy of a peritoneal dialysis program, understanding how we're doing and the outcomes that our patients are getting, and how we approach the data collection process. But I want to focus most of the time on our 2-year experience. So I'm going to show you what the first year of results looked like and the recommendations we made to the program at that time, and then subsequent to that, what's happened in 2014. And basically the point of this, for those of you who will fall asleep or have a short attention span, is that I want to demonstrate an approach to maximizing the safe and effective use of peritoneal dialysis in a regional program through the use of high-quality targeted data collection, and I'll expand a little bit on what I mean by that. So let's start with the way we approach a PD program. So this quality improvement program is basically web-based data collection built around a model of quality improvement. And over the years, we've kind of in an iterative way figured out that you can summarize a program with a handful of metrics tied to the process of care. And when we got started on this project in Calgary, we had several questions that we asked ourselves. The first one was, how is our PD utilization? Is it good? Is it bad? Can we believe the numbers that we've been generating internally? The second one was, can we actually increase the use of home therapies in the program? We had a sense that we were doing okay in terms of our prevalent numbers. Wanted to figure out, was there any room to move? Because as you all know, there was a really strong business case around that. And if there is room to move, what is it we should do exactly? And this is always the tougher question. And you know, Dr. Finkelstein's talk really nicely set this up, because there's a lot of things in peritoneal dialysis where we ask the question, well, you know, what is the choice rate in people that start dialysis urgently? Or, you know, how many people are actually eligible for this therapy? And we often don't know the answers to these questions, and so we decided we'd just start measuring it. And then we would actually know locally what are the drivers of PD use and how are they going. So this is the way we approach the peritoneal dialysis part of the data collection we do in the end-stage renal disease population. And essentially what we discovered over the years is that no matter where you're practicing, whatever country or jurisdiction or what the climate is like, you basically take people through a very simple approach to the drivers of PD use. You add people to you have this population and you're adding people to that population all the time. And then you're always losing people from your PD population. And the other important variable is how much time they actually spend on the therapy. So if you get somebody on and they last 2 weeks, that's not ideal. They don't contribute to your PD prevalence in any meaningful way. And it turns out that with the input side, you take people through 6 steps to get them on therapy. And they seem very straightforward, but in practice, they're actually quite difficult to understand and measure. The first is you have to find everybody who's got kidney failure, and in big programs, this is more difficult than you might think it is. Oftentimes, we have a number of satellite units. People start dialysis in various different places, and just getting your arms around all the people that have failed kidneys in an attempt to identify them and educate them can be difficult. The next thing you have to do is make sure you assess people and figure out what are they candidates for. So what are their treatment options? Figure out if they're eligible for home therapies, and PD in particular, and then offer it to them. So if you're a candidate, you have to actually offer them the therapy. If they choose it, and we measure choice by an attempt at a PD catheter for reasons that I can go into later, they also have to get them on the therapy. So if a patient says, yes, I'd like to do it, gets a catheter placed, and then ultimately we get them on treatment. So those are the 6 steps that we kind of track in a program to figure out how many people are making it through each of these stages? How do you look compared to your neighbors? And where might there be an opportunity to improve? So those 6 steps drive incident PD use. Those are the things that determine how many people go on the therapy. The other side of it is how you're losing people, and it turns out this takes a lot more time and is a lot more difficult to figure out. But this is basically tracking outcomes. So how many people do we lose to technique failure? How many to transplant, death, and then other forms of loss, like transfer out of a program and out-migration? So when you start collecting data, we tend to focus on the incident population. So instead of grabbing every PD patient in your program and then tracking their outcomes, we track all the new starts. And there's a lot of good reasons to do that. Number one, it's a smaller group of patients, so it's easier to do. The second thing is most of the useful information you get from a quality improvement standpoint is best gotten from that incident population. So in a program the size of Calgary's, we have about 200 new starts a year, just over that last year. And that's enough that within about 6 to 8 months, we can get a pretty good idea of these metrics that drive incident use. We need about a year to get enough PD patients that we can track meaningful outcomes. So when we started to structure the data collection in Calgary, year 1 was getting our arms around the incident population. Year 2 was where we continue that work, but then start to focus on how are patients that are on therapy doing and what are their outcomes. So essentially when we implement this program, we do a couple of things that are a bit sneaky, and one of them is that we implement something called a multidisciplinary meeting. And that meeting involves somebody who, for us, is James, who collects all the new starts and puts them onto a roster. And we sit down every couple of weeks or so and we run the list of all the new patients. And that forces us to collect them all, and it forces us to discuss them. And at that meeting, we make sure they go through a certain standard process of care, and they stay on the roster until that gets done. So, have they been educated? Have we figured out what they're eligible for? Did we offer them the therapies? Did they choose? And then did we help them get their access and get on to treatment? The second thing we do is that we train frontline nursing staff to collect this data, and we also make a commitment that this won't be an onerous task. So a lot of times we have one person who spends 6 hours a week collecting data. We've never found that model works very well because people get a bit burned out on it. So we try to limit the time commitment for the staff that are entering data to less than an hour or 2 a week on average. And we track that. So internally we've got those numbers, and once people get up and running and used to the system, we've been able to keep it to less than an hour on average per person per week. And the last part, and the more kind of innovative part of this, is that through my work in research before I crossed over into quality improvement, I gained a real appreciation for the importance of oversight. So when you collect data in a clinical trial, for example, comes in and then people review the data, and if there are any problems with it, you send queries back and kind of clarify things. We don't tend to do that with registries. We don't tend to do that in quality improvement. But the problem with that is that oftentimes you get data that's coded inaccurately, you get missing information, you have people that don't necessarily understand what you're looking for, and so you end up with data that's very difficult to make heads or tails of, and oftentimes has data quality issues. So we commit to double reviewing all of the information. 2 experts on the system review every data element that comes through. And that way we know that it's coded consistently. We know that every program we're tracking data in does it exactly the same way. And the definitions and everything are consistent. So when I compare us to Sunnybrook or to some other program, I know that I can line those things up. I'm comparing apples to apples. So there were a few things we learned in the first year of the program, and the first one was this value of accurate data. So you can always talk about data quality, and everybody says, well, intuitively this makes sense. Of course you want high quality data, but is it really that important? So could we just use our electronic health record to get this data and not go to all the work of collecting the high quality information? And this kind of highlights why you need the accurate information. On the left is the data that we collected as part of our quality improvement project. And on the right-hand side is what we pulled from our electronic health record. And this is a renal-specific database. And you can see that if you look just at the number of starts in our program, it was 210, but by our electronic health record, that number was 187. And we had underestimated the number of hemo starts. We'd overestimated the number of PD starts just because these things weren't coded properly. And you say, well, that's great, that's semantics, but this is the reason that's important. So as we spoke about moving to a model of activity-based reimbursement, the difference in those numbers would be worth $1 million a year in operating to our program. So the simple act of collecting high-quality information is by a 20-fold return in terms of the cost it took to collect the data and the expected return just by getting the numbers accurate. And we haven't made any changes yet. So that's the first thing. The second thing we learned about our program was that our patients actually look quite different. So we had this tendency to pat ourselves on the back because our PD rates were going up, and we thought, well, we're doing a really good job. But it turned out that there might be some reasons for that. So first off, our age was much lower than everybody else we'd been tracking data in all the other programs. So our average age, our median age rather, was 62 in our program, and that was much younger than most of the other dialysis programs we were in. And of course, this, you can imagine, would have some influence on your uptake of home therapies. The other thing that tracks really closely with age is comorbidity. And when we looked at some kind of high-yield comorbidities here, coronary disease, heart failure, stroke, vascular disease, all of these things were less common in our patient population than they were in others. And again, this is probably a reason that we were able to achieve better rates. So what about peritoneal dialysis utilization in the program? So I told you that we focus mostly on this input side, the incident starts, and trying to understand how we're doing getting people on the therapy, and that was the focus of the first year. And this is what we found. So in the Calgary region, you saw some of our data from SARP yesterday that Lori presented, and SARP is our entire Southern Alberta renal program. I'm going to show you some of the data specific to Calgary so that you can see the temporal changes over time. But first treatment was PD in about 26% of the patients that we saw in 2013. And that was relatively high compared to other programs that we've been tracking data in, but certainly not outstanding when you consider that Program B, the average age was 75. So they actually had a higher incident rate despite the fact their population was 15 years older than us. The other thing we do is we track PD use within 6 months. And the reason we do this is an empiric one. So when we started tracking data in programs, we realized that it takes most centers up to 6 months to get somebody who wants to do peritoneal dialysis on the treatment. And that can happen for a number of reasons, most common of which is prolonged hospital stay when they first start, the urgent start that starts on hemo with a catheter. They have to stabilize, you have to educate them, they have to pick the therapy. By the time all that happens and they get a PD catheter and get on the therapy, that can take up to 6 months. So we always report incident PD use at first treatment, but we also report it at 6 months to get a better sense of how aggressively we're going after people after they start. So when you looked at our incident and prevalent numbers and you compared us to one of the higher performing sites, this is what it looked like. So our incident numbers are in the green bar. So at 6 months, 35% of our population had received peritoneal dialysis, and our prevalent rate at the time was 25% in the Calgary zone. In the higher performing sites, they had very similar looking numbers despite the fact that their population was much older and sicker. So then we broke this down. So those metrics by themselves, there's a lot of moving parts that determine them, and you have to kind of dig into it to figure out what exactly is driving them. So the first reporting we did was on the first 130 patients that came through the program, and we took those 6 steps I told you about and figured out how many people made it through each of those. And once you've got that mapped out, you can compare yourself against others. And if you look at the percentage of people that move through each of these stages and you multiply them together, it gives you your incident rate. And the reason that's important to understand is that if you make a 1% change at any one of these steps, it has the exact same influence on your incident numbers. So if I increase eligibility by 2%, it's the same as having 2% more people choose the therapy when they're offered it. So each part is important, and you have to be firing on all cylinders if you want to increase your PD numbers. So in our program, when we looked at this, there was a couple of things that jumped out. The first one was our choice rate appeared to be higher. So more people, when given the option of choosing home therapies, were actually optioning for PD than they were in other programs. And part of this was likely driven again by age and by the fact that our population was a bit younger and more capable of doing home therapies. But it did raise the concern that maybe we're being overly promotional. And we had a look at that, and we're in the process, as you heard, of revamping modality education. The second thing that jumped out was our eligibility rates. So if you took all of the people that we assessed, about 2/3 of them were considered a candidate for PD. That number was much higher in other programs that were really aggressive in terms of offering PD to patients. And given our demographics, we felt that that was probably on the low side. So we dug into the eligibility bit a bit further. And essentially, we think of this like this diagram shows. So first off, you ask yourself, how common are contraindications to therapy in your program? So how many people have a condition, medical or social, that makes it impossible for them to do PD? And when we measured this in our program, it was exactly the same as everybody else. It was around 25%. And the next thing we do is we look at our patient population and say, are we different than other programs? Does that explain any of the differences we're seeing? And as I told you, we're younger and we're healthier. So it certainly didn't make eligibility rates lower. If anything, you would expect it should make it higher. And that's not what we were seeing. And the last issue is around support. So in the people that don't have a contraindication to therapy, they have barriers. So maybe they don't have very good vision. Their manual dexterity is not that good. They don't have a lot of other advantages for home therapies. If you provide those people with support, either through a family member or home care assistance, you can often overcome some of those barriers and make it easier for them to do therapies. So it's important to have a look at support and figure out how that plays into things. So we took the 100 people that didn't have a contraindication to home therapies and we broke them out, and we found that half of those people had somebody in the house that could help them, who was available, willing, able to help them with home dialysis if they chose it. The other half of the people didn't have anybody at home that could help them out. They either lived alone or didn't have anybody that was physically capable of helping them. And the reason we look at this is that we previously studied this and shown that the level of support in the home influences the likelihood the team will say you're eligible. It also influences the likelihood that you'll pick a home therapy. If you have more support, we seem to think you're more likely to be a candidate, and you're more likely to pick it because you feel like you're going to be okay. And that's exactly what was borne out in our program. So if you look at people with support, more than 90% of them were deemed eligible by our team. 63% of them, when offered it, chose PD, and 60% of them went on to actually receive it. So this was very high numbers. But when you look at the other group who didn't have any support in the home, those numbers were much lower. So the eligibility rates were suddenly cut in half, the choice rate was cut in half, and the number that went on to receive it was cut in half. So it raised the question for us, is this a problem? Is this a barrier to getting people home? So we went back and said, well, if support's a problem and it's missing in the home, are we using the other forms of assistance that are available, like our home care support or family assistance? And our rates were quite low. So when you looked at Sunnybrook, which was Program B there, was much older. Their use of home care assistance was 13 to 15% of their incident population. That's how many people were accessing home care assistance. For us, that number was 9%, and only 6% of the remaining patients were using family assistance, so having somebody at home help them with the therapy. The other thing we looked at was the use of PD in incident starts, so that were inpatient starts. A lot of times people parachute in, they start urgently on hemo in a hospital, and then they get lost. And we wanted to look and see, within 6 months, how many of those people ended up on peritoneal dialysis if you started in hospital. And we had relatively high rates, but what we did notice was that despite the fact 20% of them eventually got on peritoneal dialysis, almost none of them started on it. So, you know, we didn't have an acute PD program at the time. It wasn't really an option to start as a first therapy on PD. So, the sum total of all of that, and those were the highlights, was that our eligibility rates were felt to be low given the patient population we were serving. We felt that there was room to improve PD use with the inpatient starts. Our numbers still were low relative to the types of patients we were seeing. And there were very low levels of support available to patients in the home, and we were underutilizing home care assistance and family support. So we made 3 specific recommendations at the end of that first year. One was we were going to review all ineligible patients. So during our meeting, if a patient was said to be ineligible for PD, and there wasn't clear why, I would go back to the primary nephrologist and we'd have a discussion around, is it for sure this person can't do PD? And if the answer was yes, that was fine, that was their decision. But if it was a bit gray, you know, we would offer the patient the therapy and let them decide. The second thing we did was focus on inpatient dialysis starts, and we've had some success here, but it's been a challenge. So operationalizing urgent start PD programs, getting catheters placed urgently, and transitioning people home proved to be a real barrier, but it's something we were able to make some gains on. And then the last thing we did was revisit the role of home care assistants. We only had 12 spots available to us, and what we found was once we filled them up, we stopped offering home care assistance to people because we weren't sure if we could offer it to them if it was going to be available. So we sort of hit our cap, and then we didn't have any available beds. So we started to work on trying to lobby for more resources. So that was the first year of data collection. Those are the recommendations we made to the program. So let's go back and look what happened to all of those three areas that we targeted for improvement. So the first question is, did eligibility rates improve? Were we able to impact on that? And what we found in the first 120 or so patients that we've started in 2014 was that our eligibility rates bumped up to 80%. And so this now is much more consistent with other programs. And that's quite a bump, so 64 to 80%. Our choice rate remained high. And having reviewed our modality education, I think we probably view home therapies in a positive light, but we're far from coercing people, so we felt better about that. I think we were just getting and offering the therapy to more people. So our incident rate went up from 35% to 53% in the first 112 starts of 2014, and that was driven by the increase in eligibility rates. And I want to pause here for a second, because had I just seen, so the first thing I did when I saw this number was I told my analyst, you have to go back and do this again because I don't believe that. And so she did, and we went through every patient, and sure enough, it was 53%. The second thing, though, is that you often, with small numbers in quality improvement, get spurious results. So sometimes things just kind of come in waves, and you'll see numbers move all over the place. There's a lot of variability. So it's helpful when you see a bump like this to ask why. And if you can trace the improvement back to the step in the process of care that you targeted, so the eligibility rates, when I see that bump by 20%, and that was where we had focused our efforts, and that translated into an improvement in outcomes, it's reassuring for me that this is more likely to be real. Now, what's the rest of the year going to look like? I don't know. But we've already started more people on PD in 2014 than we did in all of 2013 in the first 6 months. So did PD increase in inpatient starts? So this was another area that we specifically targeted. And our inpatient starts, so within 6 months, if you started in hospital, 30% of patients in 2014 were starting on PD compared to 20% the year before. So we did see a bump in the inpatient starts. Were more people receiving assistance? So I didn't put this one first because I'd really take the wind out of my sails. Basically not. So we've struggled with this. I still worry that our ability to offer people assistance is still limited, and we're trying to fix that, but it has been a difficult road. The other question for me that is not clear is whether this is important. So we're seeing very high incident rates. Is the lack of assistance really limiting us? And the way we're going to figure that out is to go back, look at the people that weren't eligible for therapy, and see if the availability of assistance actually played into that decision. If the answer is no, then it's probably not something we need to spend a lot more time on. But if we find that there was a significant number of people that would have done PD had they had assistance, then I think we need to look at the role of home care support. And how has PD use changed? So we talked about this disconnect between incidence and prevalence. And when you look at that initial conceptual framework I put up there, you kind of understand why. So if you've got a program that's 230 patients and you're adding 40 or 50 each year, changing your incident rate even dramatically doesn't necessarily have a huge impact on your prevalent population. It takes years to see that effect, and you still have this issue of loss, and we haven't talked about that at all. But when we looked at incident rates, PD as a first treatment within 6 months went from 26 to 45%. Sorry, as the initial treatment. Within 6 months, it went from 35 to 53%. So we've seen bumps in both of those things. So not only are more people starting on it, we're able to convert more of those people that started on hemo onto PD. And that's done simply by identifying them, educating them, and letting them make an informed decision. It's not going up to them and saying, you've got to get off this evil central venous catheter and hemodialysis and get onto home therapies. is really just letting people make an informed decision, which I as a doc feel good about, because then I'm really just doing what I should be doing, which is providing informed consent, and then patients do what they want to do. So these were how the incident and prevalent numbers shook out. So initially our prevalent numbers were about 24%, and that in the Calgary zone has increased to 27% over the course of the last year. So what about the outcomes? So with year 2, we had over 100 patients on PD that we could then start to follow and see what happened to them. And with those 92 PD starts, we lost 16 of them. So about 17% of the population failed. Of that failure, about half of it was technique failure, another 40% was transplant, and we had a few deaths and a few transfers out or recoveries of kidney function. So almost 80%, more than 80% of what we saw was either technique failure or transplant. That's helpful to kind of know what the distribution is, and it kind of comes back to a point that was made earlier. You know, if you drop your peritonitis rate, and peritonitis is half of the cause of technique failure, which is half of the cause of loss, you really don't expect you're going to see a huge change in your prevalent numbers. It's important to do, but you can understand why even a dramatic change in one small component of loss doesn't necessarily translate into a huge difference in prevalence. The other thing is that it's important when these things happen. So technique failure that happens at 1 month is very different than technique failure that happens at 4 years. So it's helpful to actually plot these things out. And we do this a couple of ways. One is just a crude survival curve so that you can actually see when this loss is happening. This one is not that. This is called a cumulative incidence curve. And so as time marches on, this plots how many people have failed peritoneal dialysis. And so it goes up with time. And these curves we adjust, we take into account the competing risk of death and transplant. So it kind of evens the playing field if you've got death or transplant, because once you've had one of those things, you can't fail. You're not available to fail peritoneal dialysis. They're also adjusted for baseline characteristics. Because we were younger, because we had fewer comorbidities, it's not fair to compare us to a Sunnybrook, for example. So we have to adjust for those things. And we felt pretty good about this because our initial data would suggest that the first 100 people we've put on peritoneal dialysis and tracked, you know, their technique failure rate, if anything, is on the low side, even accounting for all that stuff. So we've had 2 years. The first year was really focused on the data collection and making some recommendations. We've now been able to track some of the preliminary outcome data. Where do we go from here? This support and assistant issue is really, you know, something that's a bit of an outlier. We were able to make some gains on the inpatient starts. We've increased our eligibility rates. Now the focus really is in on this assistance and the role it's playing. So we're going to figure out if assistance is actually impacting on PD use, and if it is, the next step would be to try to work more aggressively at getting more assistance for patients. We're going to continue to track outcomes and make sure we maintain good outcomes. And then it raises the question of whether we need to shift focus to other areas. You know, I think it's important to continue to track this data to make sure that things don't start to sink. If they do start to sink, understand why. But I think it's also a good example of priority setting and using data to drive decision making in your program. You know, I like PD, I'm interested in PD, but the reality is focusing our efforts on growing our home therapies further is probably going to be very low yield, and maybe not the best use of resources. Maybe we should shift our attention to the hemo population and look at our use of access and procedure rates and things like that that are driving resource consumption in our program. And that's the other part of the quality improvement work we do. So we don't just look at PD in isolation. We're actually tracking how patients are doing on all of the therapies, how we're consuming resources, what the patient outcomes are. And, you know, it's an example of how we approach this. And I was always that kid that drove my parents crazy. They tell you something and you say, well, why? And then they tell you it again, and you say, well, why? And they'd throw you out of the car. But you know, I'm kind of the same way with this stuff. It always drives me crazy when you see something and you can't explain why. And I think that's why I like doing this quality improvement work. It allows you the opportunity to really look under the hood, figure out what's driving the outcomes, tie it to process, and then clean it up. So in terms of tying it all together, I think, you know, as I mentioned, there's value to having high quality information, but not just high quality data. You have to tie it to process. Understand the steps we go through to accomplish an outcome, and make sure that we understand where we're doing well, where there are issues, and try to improve. The other thing is that quality improvement, if you're going to do it like research, you have to make it feasible in everyday practice. You can't do it like we do trials. I don't have, $100 million to invest in quality improvement for Alberta. So we really have to develop a model that gets us the high quality information that's helpful, that we restrict it to the stuff that is helpful, and that it's feasible to implement in everyday practice without a lot of additional resources. I personally feel that this kind of process is actually required if you want to identify, is there a problem, and you want to understand why is there a problem and try to fix it. So often decision-making in programs is just, I think this is a good idea, and we have to make decisions like that because we don't have data to help us make those decisions. But when you have the ability to collect it, understand where there are problems, it allows you to prioritize and say, of these 15 things that might be good ideas, let's focus on these 3 because they're likely going to address problems that we have locally and actually improve stuff. And then the last issue is the business case. In this environment, you can't underestimate the importance of targeting areas that actually have a very good return on investment and maximizing the use of home therapies in a safe and effective way that's patient-centered has a really strong business case. If you look at the numbers of patients that started on peritoneal dialysis last year, that bump of 20% for us, 20 patients extra this year so far. For us locally, there's a delta of $25,000 in operating per patient. So that, again, by itself is worth over $500,000 to us in the first 6 months of the year. So there's tremendous cost savings if you do this well, and you think about interventions that actually have a strong business case. And maximizing the use of home therapies is a no-brainer in terms of the business case for it. So I'm going to stop there. I thank Dr. Oliver, who's been my partner in crime on this for the last decade or so, and all the managers, physicians, and staff at the programs that have supported us over the years.